Well, in the interest of trying to stay as close to being on time as we are, which is not very close, we'll move right into our next talk. This is Lillie Shockney from Johns Hopkins University, a very well-accomplished person in the field of breast cancer who is going to talk to us about patient navigation. I think it's very important that we realize that whether you have a golden system or a system made of dung, there are ways in which you can navigate through those systems, and patient navigation is quite critical for that. So Lillie, thank you.
Thank you. I do have quite a few slides. I'm going to abbreviate some of them so that hopefully we can get a little bit back on track. Keep in mind that Ben has arranged, though, for these PowerPoint presentations to be on the website. And Ben, thanks very much for asking me to come and partake of this important meeting. Before we can talk about navigation, it's important to talk about where did it come from. And though it actually officially goes all the way back to retrospective utilization review done by insurance companies in the early 70s, I'm going to begin looking at a term that actually changed from case management to navigation, and that began actually in the mid-1990s. And the objective for case management, which was conducted by nurses, most particularly usually advanced practice nurses, is the collaborative process which assesses, plans, implements, and coordinates, as well as monitors and evaluates the options and the services required to meet a patient's health care needs, using communication and available resources to promote quality and cost-effective outcomes. And this just wasn't for cancer. This was for all life-threatening illnesses and chronic diseases. In looking at case management, there was a study that was published just in the 2003, but it reflected back during the 1990s, and it was related to older breast cancer patients. So these women were over the age of 65. And the objective was to evaluate the effect that the nurse case management program had on the diagnosis and treatment of older women with this disease. And it was done as a control study, a randomized trial. And the measurements, the first one was, the outcome was the type and the use of specific cancer therapies during the first 6 months after a woman was diagnosed. The second outcome was the patient satisfaction and arm function at 2 months after diagnosis. More women in the intervention group did receive, and this was very important to measure what those treatment modalities were. More had breast conservation performed, did receive radiation therapy, reconstruction if mastectomy was performed, which was low, axillary node dissections when appropriate, and chemotherapy if they had advanced cancer. And yet, even at those, you see that nothing is at 100%. And still is not today, but is getting there. And return to normal arm function, and this was related to the axillary node dissection and arm movement for some patients being difficult. Among all of the women having breast conservation, more had adjuvant radiation therapy as well in the intervention group, and that was a very wide difference of 78.3% compared to prior to that 44.8%. Some of you may be familiar with Dr. Harold Freeman, a physician in New York City working at Harlem Hospital, who also at the same time the case management came into being across the United States, he actually created the term referred to as patient navigation. And his focus was on cancer, and most particularly on underserved populations. His mission was to identify and reduce barriers to timely cancer diagnoses as well as treatment. And he wanted to focus on minorities and other underserved populations. And that navigation did prove to be successful under his auspices. He defined this as being a process by which an individual, a patient navigator, guides a patient from the point of recruitment for a screening mammogram through to diagnosis of breast cancer and its treatment, and identify and remove, and the key word there is remove, barriers to care and treatment, and that this can be done by one individual or several individuals performing it as a group function. So it certainly does depend on the settings and the needs, and I hear commercials on the radio at home where a breast center will be advertising that they have a patient navigator for each of their patients. I've also done some secret shopping. I have to use a friend of mine's cell phone, though, because I think some of these people know my number, and they certainly know my work number. And I'll ask, I'll say, my sister's just been diagnosed with breast cancer, and I heard your ad on the radio, and it says that she'll have her own patient navigator. Can I talk to that patient navigator now? And you can get some wonderful information asking these questions. Usually the people on the other end of the phone are incredibly honest. One said to me, "Oh, well, that's just for the commercial that we have on the radio." Another one said, "Well, it's actually the person that schedules the first appointment. That's the patient navigator." I said, "Well, what happens after the first appointment?" She said, "I don't know." So navigation is not navigation is not navigation. You have to dig in and find out exactly what people mean. But its overall purpose is to reduce the incidence of cancer, which certainly we are trying to accomplish globally as well, and mortality, which we've certainly learned a great deal over these last 2.5 days, that's a very high incidence for developing countries, and improve the quality of life of people who have been diagnosed with cancer. And we heard quite a bit about that also already in looking at palliative care. Provide culturally targeted education, provide access to early screening as well as early diagnoses and treatment that's going to be delivered in an efficient way, and provide assistance and actual navigation, helping them take this journey through the complexities and the barriers of our healthcare system, which I think have become more complex in the last 10 years. This individual is going to be responsible, or a team of them, to address the psychosocial needs of the patient and the family, assist with treatment decision-making. Oftentimes we do ask patients to participate in decision-making if they aren't well educated and empowered to do so. How can they possibly do that? Assist with insurance for those countries that have health insurance. There's lots of carve-outs of insurance today, so a patient may be having a screening mammogram in one location, directed by her insurance company to go to a different location for diagnostic evaluation, yet a third place to see a surgeon and have her operation, a fourth place to receive her chemotherapy, and a fifth place to have her radiation. That's an awful lot for a patient to have to navigate through on her own, particularly when she's so frightened, having heard those words, "You have breast cancer." And inform patients of what the services within your facility as well as within the community are that are available and that she can be connected up with. Coordinating transportation, which is one of the #1 reasons why minorities in the United States do not receive appropriate care, because they can't get to where the care is. And increase health awareness of individuals. Coordinating these services, tracking the interventions and the outcomes, and that's very important. You cannot manage what you do not measure. And build relationships with other patient navigators so you can learn from one another and exchange those good ideas. But the overarching role is to stay in close communication with the patient across the continuum of care to ensure that that care is coordinated, is given in an efficient manner, and that the barriers to that care are removed